I think anyone working in hospital in the home has to be a disruptor. We're disrupting cultural norms or what we've created as the norm of healthcare. We need to think about things differently and we need to bring everyone along with us, and change is really hard.
I'm Dr. Louise Messara, and this is the Future Health Podcast. In 2020, the US government reduced regulatory and funding blocks, and 203 hospitals across 92 health systems in 34 states began to deliver inpatient hospital-level care to clinically appropriate acutely ill patients in their own homes. The hospital at home model in the US and others like it right across the world have published evidence of improved outcomes, increased patient satisfaction, and decreased resource utilisation. So when we next hear the ED is full and ambulances are ramping, should we join the call for more hospital beds? Or will innovation and technology increasingly give us the tools to deliver hospital-level care in non-hospital environments? Today, our guide to the future of out-of-hospital care is Dr. Alexander Beath. Alex is a GP and the medical lead for Hospital in the Home in Northern Sydney LHD, as well as a board member of the Hospital in the Home Society of Australasia. Welcome, Alex. Alex, the US loves to claim to be at the forefront of many of our health innovations, but Australia's got a long history with hospital in the home. So what do you think the US learnt from the pioneers in Australia?
I think in many ways I'm quite jealous of the US. They're able to approach the hospital in the home movement with a fresh lens, with a tech-enabled hospital at home in a post-pandemic world. What they've learnt is what can be done well and new opportunities in hospital in the home.
So they sort of got to start from the ground up, I suppose, in a way where maybe in Australia it's been a little bit, well, learn as you grow. Is that the sort of their main advantage, do you think?
Yeah, I think throughout Australia, one of the big problems with hospital in the home has been variability. Some hospital in the home is actually more of a post-acute model. Some hospital in the home is a truly acute model. And the Americans essentially are defining what hospital in the home should really be, 24/7 acute hospital substitution.
So, I mean, that's important. In Australia then, where it's hard to generalise about what HIF is here, because it sounds like from what you're saying, one hospital's program might be different to the next. Are there leaders here in Australia that you think are sort of shining a light on maybe the way we should be moving forward?
So recently, the variability within hospital in the home has been identified as a real issue. And the World Hospital at Home Congress defined what hospital in the home is last year as acute 24/7 hospital substitution. And then the HIF Society of Australasia has done the same and provided a definition for what hospital in the home is. It's actually created a bit of controversy amongst different stakeholders. There are public-private partnerships doing virtual hospitals. And as a board, we are constantly monitoring what is the best way to define hospital in the home. How do we define rehabilitation in the home? How do we define palliation in the home, hospice in the home, geriatric evaluation and management in the home? But these definitions are really important for standardisation, for funding, and for research to ensure that when we're comparing hospital in the home models, we're comparing the same thing.
It's almost a learning circle here. So things started off here and elsewhere in the world. America has picked up and run with the baton. Are we now learning from what America's done? And is that what is informing these changes to the definition?
I think what the Americans are doing is very exciting for Australia and the rest of the world. They're producing some amazing literature. They're setting up councils between academics, tech industry, and other stakeholders in a multidisciplinary approach to go, how do we do this logistically? How do we increase the acuity of patients we can look after? And it's really boosted the collaboration between nations around how we deliver this model of care. Recently, there's a Cochrane article that's come out in March that's saying that research needs to move away from is hospital in the home a good model to how do we implement hospital in the home models. So that is really the next step, is how do we do this properly? How do we scale this? How do we use tech to assist in scaling this? And how do we monitor that to ensure that we're delivering equal or better care than brick and mortar hospitals?
Do you have any favourite examples of institutions or organisations that are doing this now already well, that are your sort of go-to institutions?
Yeah, so Jared Conley was our keynote speaker at the Hospital in the Home conference this year. He comes from Harvard. He runs a health innovation lab in Harvard, and between him and David Levine are really doing some cutting edge work in the home. Our keynote speaker this year from Barcelona is running a master's hospital in the home program, one of the first educational programs for hospital in the home clinicians.
When we think about how those exemplar models might differ from the system you run here at Northern Sydney, where are the gaps and where are the leaps to be made?
I think what we all need to aim for is 24/7 care, tech-enabled care, increasing the acuity of patients that we are taking, scaling our programs. It needs to be a whole-of-hospital approach. It needs to be targeting
whole-of-system approach.
Whole-of-system approach, analysing between all the different stakeholders what patients are safe to be at home, and how do we make that happen.
Is Australia ready to answer that next question of, okay, yes, it's a good model, how do we implement it? Is Australia ready to implement the improved acute version of HIT?
I think we are ready. I think we've got experience, we've got expertise. It's not cheap, but it's cheaper. The model in America was 38% cheaper than brick and mortar. Obviously, it doesn't have the capital cost of building a brick and mortar hospital.
But still, the model that certainly I referenced in the intro talks about 2 site visits a day, e-health visits by physicians. It's a serious investment in workforce. So yes, no brick and mortar, but I presume if we looked at your FTA at the moment, we'd need to put some serious investment into workforce. Would that be fair?
Yeah, it needs to be approached as you would approach building a ward of a hospital, with similar funding mechanisms, similar resources, similar approach. They're the features that are really required to scale this.
We hear a lot about virtual hospitals, virtual care, and that's sort of like the buzz thing, and you can go to a million conferences at the moment about virtual care. What's the interplay between virtual care and hospital in the home? How do they fit together, or do they?
Virtual care is a modality that can support any aspect of a hospital, can support the outpatient department, the brick and mortar department, the emergency department, ambulance avoidance. So virtual care has to be embedded in every single model. Where I see virtual care and hospital in the home merging is assisting with the front door, assisting with the back door, assisting in that hybrid model, which will enable us to scale. Not all patients will need to be seen face-to-face morning and night, but there needs to be the face-to-face component built into your hospital in the home model. I think really in that hybrid model that will be successful.
You referenced the recent stats coming out of US around cost reduction. I think they also reflected a 70% reduction in readmissions, 50% improvement in patient mobility, and I think there were even some mortality improvements. Are you at all surprised that this model of care can bring about these sorts of results?
Patients often have better outcomes at home. They're not lying in bed all day. They're getting up and making a cup of tea. They're not getting that DVT, the deep vein thrombosis. They're not getting that hospital-acquired pneumonia. Patients want to be at home, and they tend to do better at home. In terms of hospital-acquired complications, 1 in 50 patients in a public hospital will suffer a hospital-acquired complication. And one of the major arguments for hospital at the home is it's often a safer model of care. What we're finding with 24-hour tech and 24-hour monitoring in the home is that sometimes we're getting a lot of false positives. Patients might have a heart rate of 120, but they're out washing their car. And so one of the big things that we're working out is who to monitor, when to monitor, And are we over-monitoring patients because we can't always control what they do when they're at home?
Is the proposal that you have more continuous monitoring at home than you might for that same acuity in a hospital where we might be doing 4-hourly obs?
Yeah, so this is one of the big questions. I mean, we have the tech to do 24/7 monitoring of every patient, but do we necessarily want to use that 24/7 monitoring for a patient who is quite stable with simple cellulitis? Or do we want to measure them 4-hourly or twice a day or daily? These are the things that we need to research and analyse and study so that we're not adding to a patient's burden by over-monitoring them.
So if we've got some reasonable evidence that it's a cheaper than bricks and mortar option, and we've got some reasonable evidence that it can be done without compromising on quality of care, why are we not all doing it?
I think there's an element of cultural shift. You know, when we have a patient who is unwell in the community, the default is to get them to a acute brick and mortar facility. And so what this will actually take is an entire cultural shift, a cultural shift of policymakers, a cultural shift of clinicians, of health administrators, of leaders, of the community.
Mm-hmm. I mean, that's interesting in terms of how we bring the community along on this journey. Nothing can be done sort of without them. We know that people would prefer to be at home. We know that people would prefer to die at home. That's plenty of evidence around that. Do you think it's going to be much of a sell for patients that they can be cared for and delivered the same quality of care at home as in a hospital? Or do you think they're almost there?
When I approach a patient, most patients want to go home. Sometimes they need to be reassured that the care that they're going to give is the same as what they would receive in hospital. They need to be reassured that they can call someone at 24/7 times of the day. And once they're reassured with that, they're very happy with the hospital and the home model.
Does it place an extra burden on family members and carers, and is that something that we need to be thinking about?
It can do, but in Australia, we care for people who don't have anyone at home and are alone at home.
Okay.
What hospital in the home does is it assists patients who are housebound. It assists patients who fear hospital for whatever reason. It assists our Aboriginal and Torres Strait Islander patients who may have had traumatic experiences in hospitals or had relatives who've had traumatic experience in hospitals. So from an equity perspective, there's a very strong argument for the model. Patient experiences are really important. Recently, I treated a man who was quadriplegic in his home, worked in the mines remotely in Perth, with a serious catheter-associated urinary tract infection. And the referral came from the GP to the hospital and the home program. We went into his home, administered care, treated him for 7 to 14 days. Now, that would have been another brick and mortar hospitalisation for that patient who'd had hundreds of hospitalisations and was actually quite a late presentation because he was avoiding hospital. So there is definitely a subset of patients who really benefit from this model of care.
You talk about equity, and I take that point. I think sometimes we're asked to consider, just because we can do something, should we? Are there potential pitfalls which maybe the Congress or your board are grappling with as you seek to sort of roll this out in an expanded way? Issues of, data protection, issues of ethics or unanticipated risks that are at the forefront of your mind when you're thinking about the program?
I don't think that hospital in the home is a panacea. I can really see it assisting 5 to 10% of our hospitalised patients. I think it is part of the solution. I think the risk in any hospital in the home program is picking the wrong patient. And for that, you need skills and expertise in the area. We don't necessarily have a training program in hospital in the home. Spain is starting up a master's. As a board, we're realising that we need more subspecialised education in the area because it is, in a way, its own specialty.
Do most of the clinicians at hospital and home come through a sort of a GP pathway, or are there hospitalists involved as well?
So I'm a primary care doctor, a GP. Most physicians working in the hospital and the home come from an infectious disease background, a general physician background, geriatricians, FACEMs, emergency physicians, general practitioners.
Do you see it eventually as its own college?
Definitely. I think it will definitely be a specialty at some point. The amount of information you need to learn from a logistics perspective, a delivery perspective, and a medical perspective is immense. And just training new doctors in the area takes time, effort, and I think to make it more of a formalised process would be definitely important for the future workforce in the area. I think it's really important that we think about the future, not only the future of doctors working in hospital and the home, but nurse practitioners, nurses, allied health, because it is very different from looking after patients in their home from looking after them on the ward. And we have to look at training pathways across all disciplines, not just with the doctors.
100%. If you were selling a career in hospital and the home to a new cohort of interns coming in, what are the qualities or strengths that you'd need to have when we think about sort of the attributes of doctor to profession?
I think the generalist model works really well because then your program isn't a OPAT or an outpatient parental antibiotic therapy program. It's a hospital at home program where you're not looking at a patient based on their DRG and whether it fits your DRG criteria. You're looking at a patient as a whole. They might have a decompensation of their heart failure. They might have an infective exacerbation of their lung condition. But when you're looking at the patient as a whole and seeing even how their home environment is affecting the reason why they keep bouncing back into hospital, and then adjusting not only the infective exacerbation of their lung condition, but looking at their home environment as a whole. And I think that's where it's really attractive from a general practitioner mindset or a general physician mindset, where you can look at all the different factors and whether you can adjust them. On our program, we have 2 social workers, and going into someone's home is one of the best social histories that you can take because you get to see what's in their fridge, what's in their cupboard, or what's not in their fridge, what's not in their cupboard. Are they taking their medications? Why aren't they? What are the reasons for that? And so you can actually delve quite deeply. It's quite a interesting position as a healthcare provider.
If you were unburdened from the way our health system has developed and the funding models that sometimes constrain us, and you were looking at establishing for New South Wales a hospital at home, hospital in the home program, what's your vision for that?
I really like the medical assessment unit model, and the way I often try and educate my colleagues around what hospital in the home can be is it can really be a medical assessment unit on wheels. So everything that it would take to build a medical assessment unit, junior doctors, registrars, senior clinicians, multidisciplinary teams, pharmacists, all with the ability to provide care in the home virtually and face-to-face. And if you can build it as you would build a normal ward with a few simple adjustments, then you've really got a hospital in the home that's potentially incredibly proactive.
Do you see opportunities for public-private partnership here? I know there are sort of some artificial barriers at the moment, but is there a chance for us to work more collaboratively across the whole system?
I think there is a chance for us to work more collaboratively. There are definitely public-private partnership models that are happening in other states. I mean, one of the big challenges for private providers is the lack of standardisation between hospital and the home products. And so it's really important that we attempt to create a standardisation so that they're happy to fund what we're delivering. In New South Wales, none of the public providers of hospital in the home have deals with the private insurers so that patients are able to utilise their private insurance for hospital in the home. And I think that's problematic. If anything, in New South Wales, some of the private providers are really driving the innovation and driving the change and driving the models. And I think it's important that, when our hospital system is full at capacity, that we look at private providers or we build them into our system planning.
returning to sort of deliver care back in the home, sort of taking health full circle in a way, do you think there will be much resistance from your colleagues to an essential change in work environment and workplace?
Yeah, I think it's disruptive. I think anyone working in hospital in the home has to be a disruptor. We're disrupting cultural norms or what we've created as the norm of healthcare. We need to think about things differently, and we need to bring everyone along with us. And change is really hard. We need to continue to educate why there is benefit in this. But we also need to ensure that we remunerate individuals to assist in this change. Do we need remuneration for GPs referring directly into hospital in the home models? How are we going to remunerate our physicians once patients are in the hospital in the home setting? What are the incentives to drive change? Do we need incentives? Is that the best way to go about things?
Should home become the primary place of healing again? I mean, if the system's so oriented at the moment to hospitals, but do we need a public health awareness program? Do we need a campaign out there to give patients the confidence and give clinicians the sort of vigour around the importance of this model for patients and how, for patients and families, this can be transformative?
I think one of the biggest comments from patients at the end of their treatment with me is, I didn't know this service existed. And so I think we definitely need to ensure that the public knows that this is an option, that this is a service that exists, that this is a choice. And sometimes patients ask their brick and mortar clinicians if they can be managed at home. I do think it needs publicity, and it's one of the reasons I'm here talking to you today, is to make it mainstream. I think what the hospital in the home society has really discussed over the last couple of weeks is that a lot more happens in hospitals than a physical ward bed. And that's where we need to embrace all the other at-home care models. In America, they have the American Society of Home Medicine, and that encapsulates palliative care at home, hospice at home, geriatric evaluation management at home, all of these new innovative models of care that are still really important. I think the biggest thing that everyone needs to understand about hospital in the home is that it's inpatient substitution. It requires resources. It requires expertise at a very high level so that patients remain safe at home.
So I have two things on that. Number one, are your specialist hospital colleagues ready to transition their patients to this care? And number two, are the administrators that you work with on board understanding the opportunity for the system that hospital in the home offers? So are you getting the support from both those groups?
I think there's some support from some groups and less support from others. I think a lot of that comes down to their understanding of what their hospital in the home program was when they were training. And a lot of it comes down to trust. Referrers need to trust the system, trust that it's a safe service, trust that it's a reliable service, and trust that it's an easy service to refer into. We talk about interoperability. The system needs to be easier to refer into than any other system. So when we're trying to get a referral from a GP, often it's easier for a GP to send someone to emergency than it is to send them to a hospital in the home program. Now we need to improve that. And it needs to be easier for someone in emergency to send that patient to a hospital in the home program than to send them to the brick and mortar ward. And so these are often the barriers that we see. And this is what we need to improve on. We need to improve on the referral pathway, make it easier for referrals, and improve on interoperability. And this is where I see with a single digital patient record real excitement and enthusiasm, because real opportunity essentially, particularly with remote patient monitoring.
It's an interesting question why it would be more difficult to refer a patient to you than it would be to send a patient to the ward. Is it just historical patterns of practice? Do we just need to crack that? Is there any reason why the system doesn't trust hospital in the home yet? Where's the history of that come from?
It's very variable between different districts and different hospitals as to the processes. I think one of the major changes moving forward is some hospital in the home programs have been purely a nurse-led model. And I think the danger of that is it needs to be a multidisciplinary model. And medicine is a discipline and it needs to be part of that, because governance is everything in a hospital, as it is in a hospital in the home program. And having internal governance with hospital in the home specialists caring for patients in their home with the assistance of all the subspecialists, all the radiology, all the pathology that's required is one of the best models for it to work.
It sounds like, Alex, that there's a clear path to where we want to get to, and solid evidence as to why we should be looking at this as a genuine pathway out of an ever-increasing bed number in hospitals. But it also sounds like there are a variety of barriers that are in your way to making that a reality, at least in New South Wales, tomorrow. Can you talk to us a little bit about some of those barriers and how you think we can break them down?
To use your term, it's really going to require a whole of systems approach. It needs to require ICT and our IT colleagues. We need to be building it into the single digital patient record. We need to be building it into our remote patient monitoring. We need all players in the system working on the right solution to improve the interoperability. But we also need to ensure that our hospital in the home programs are similar in Wollongong from Newcastle and Lismore and Sydney, so that when patients move up and down the coast, or we're referring up and down the coast, that we have similar platforms, similar approaches that have the nuance of their local health district built into that.
The body that you're on the board of now, is that the work it's doing, trying to bring conformity across New South Wales or across Australia?
So that's one of the big roles of the board currently, is looking at standardisation. At the moment, we're conducting a research project of all the hospital in the homes in Australia to understand what is every hospital in the home doing, what aren't they doing, so that we can actually figure out where we are now and where we need to go.
Outside of medicine, are there specific training programs and courses that nurses and allied health staff are engaged in now in relation to hospital in the home?
So most of our nurses come from a critical care background, emergency, ICU or oncology. I mean, all of our nurses can cannulate. I mean, what hospital do you go to where all the nurses can cannulate? They're highly skilled, highly trained. What we need to do is produce a training program that gives them direction around what skills are required. So the Hospital in the Home board at the moment is creating position statements around what it is to be a hospital in the home nurse, what it is to be a hospital in the home doctor, what traits do you need, what skills do you need, and where could your career take you on a career trajectory path. So these are the things we're working towards, and I think they're really important.
Alex, this is going to be a really important part of how we deliver care into the future. Thank you so much for being with us today.
Thanks for having me.